Hi, I'm Dr. Kawita Bapat. Today's topic is surgical skill, born, innate, or made. This is a very topic very close to my heart and very important topic. Now, the introduction is in context to surgery, experts can be defined as experienced surgeons with consistently better outcomes, whereby they demonstrate superior performance and in multiple skills compared with the non-experts. So the important point, despite the controversies that exist, the Darwinian concepts of a natural selection and survival of the fittest is well established. So according to Darwin, we know it, the natural selection and the survival of the fittest, these two thoughts are important for the surgeon made, born, or it innate. So the such theory can be used as a starting point to argue the discussion. There is a vast amount of research in the literature attempting, number one, to elucidate the attributes of expert, and number two, the steps involved in the development of expertise. Now, the two questions that must be posed collectively are, number one, how important are the innate abilities in the development of surgical expertise? And number two, the appropriate training, can sheer determination, hard work, and a practice be enough to turn an individual into surgical expert? So these two questions should be answered. Now, the development of the competence, with a lot many years we have given in our practice, and we come to know that making a competent surgeon has always been a priority of our profession and for the public also. The universal definition of surgical competence has been deemed rather unattainable, and there is a role of a formal framework is needed for the competence, how to define it, how to document it, and how to assess a surgical competence. So these three questions, we need a formal framework. And for that, the development of the competence, different competence of roles of the competent surgeon. According to the behavioral approach, competence is assessed by precise measure of performance and generally documented by checklist. Number two, it can be the holistic or the integrated approach, which defines it as a complex combination of personal attributes. Number three, in the surgical arena, we can define what is a competent surgeon is. A competence is the ability to successfully apply, number one, professional skill, number two, knowledge, number three, attitudes to new situation and a familiar task. Now, for the development of the competence, an important step in assessing the competence is developing robust methodology, because we need how we can assess anybody's competence. So we need a robust methodology, and for the evaluation and as well as for the certification. And the adage is the see one, do one, teach one. So after this three, we always say like a kahawat, see one, do one, teach one. This can be a methodology for development of the competence, and is familiar to the surgical trainees is very important. Now again, the Miller introduced his famous hierarchical triangle. It is comprised of four levels, where from base to pinnacle one knows, then knows how, then third, then shows how before reaching last and most important, the final stage is does. So one knows how, shows how, and final stage is done for the development of competence. Now, Howell's model constitutes similar phases where a novice initially migrates through phases of, number one, there is always an unconscious incompetence. Then with the training, they can become a conscious incompetence, means they know the work, but they're consciously incompetent. Then third is the conscious competence, and number fourth is unconscious competence. So this is the last stage, which is very important for the development of competence. Again, for the competence, because through performance built on the competence, it depends on the other personal or systematic factors. This is a Cambridge model taking into this consideration. This model distinguishes competence from performance. Now, the attributes of a surgical expert. It's vital in a model surgical education to cultivate surgeon into appropriate technical and non-surgical skills. We need a both type of skills, a technical skills also and a non-technical skills. And non-technical skills are really important to becoming a surgical expert. Number one point is knowledge depth. One should have a great knowledge. Number two point is a professional value, such as a team working and a communication skills. And number third point is judgment to be member of a multi-professional scheme. So judgment is also very, very important. When to give decision, when not to give decisions is a point. And the last is a decision making, especially under pressure, is a crucial for the surgical expert. So these 4 points are a non-technical skills one should have to become a surgical expert. Now, again, these are the surgical experts. Experts are better in monitoring and evaluating their own performances. They are very well developed capacity or the capability to detect and correct the errors. Then there is an effective and efficient at solving operative dilemmas. Then there is a forward reasoning to reach diagnosis and treatment options. And they are able to reach automaticity in a surgical task. The non-experts, in comparison to the experts, on the other hand, primarily depend upon the feedback from the external sources for error detection and correction. So there is a great difference between the experts and non-experts. Now again, there are the surgical expert. Interestingly, it has been shown across the worldwide that the surgical specialist, there is a clear and consistent relationship between both surgical volume and operative outcome. It's very, very important. The first and foremost, if there is a great surgical volume and an operative outcome, will be improved patient outcome. First thing, there will be a decreased length of stay of a patient. The complication rate and mortality and adverse outcome will be very less, and the failure of surgery will not be there. And last and most important is improved clinical results. So surgical volume and operative outcome has got a great role for the attributes of the surgical expert, and the benefits derived from number one, targeted training, adequate experience, and third is a frequency of performing a surgical procedure. Now, the Galton and Innate, these are the researchers who have done the research on recognizing and developing the scientific basis based on the skill acquisition and innate biological capacities. He also states that it's a relevant heritable capacity set an upper bound for the individual's mental and physical achievement. Second point is that once all the training benefits has been attained through a sufficient practice and the immutable limit of performance is subsequently reached, this is the point. And again, according to Galton, it is established that the essential skills in a minimal invasive surgeries are it's a visuospatial awareness and fine motor dexterity. So it can be inherited and it can be developed. Now, the Hoffman et al. Attempts to determine the desirable personality traits like a high, conscientious, extroverted, and emotionally stable individuals. The latter study discovered that the novice subjects clustered into 3 groups for the surgical ability. A group who are innately gifted. Number 2, a group who were able to reach competency with a repeated practice. And third, a group who could not achieve a basic competency despite repeated practice. So this is the Hoffman who has done all these studies, and they found out it's a mix of the thing. Now, the motor skill and acquisition and retention factors also very, very important. The acquisition of motor skills and implications is a 3-phase theory. First is the cognitive phase, second is the integrative phase, and third is the autonomous phase. In a cognitive phase, even understand, practice with allowance of making errors. In an integrative phase, there is a performance become more better, and then an autonomous phase without much conscious effort, that's an autonomous phase. This is the concept. So the motor skill and acquisition retention factor is again level 1, and allowed by the Dreyfus and Dreyfus identified 5 levels of skill acquisition. Number 1, level 1, novice. Level 2, advanced beginner. Level 3, competent. Level 4, proficient. And level 5, expert. So it's a Dreyfus and Dreyfus theories for skill acquisition is very popular, and it can be used for many things. Basically, these theories were used for the pilot training also, and they are there. So the can surgeons be made? Very, very important point. Either they are born, innate, or made like that. It's interesting to note in 1918, Jasper Halfpenny, a Canadian surgeon in Winnipeg, presented his paper, The Training of Surgeon. That was the title. It came into the Hamilton Medical Week. According to him, as to surgery, surgeons are made, not born. The making process we call education, and it commences with the child begins to use its hand and taught to use both hands equally well. As it grows, it should have its reasoning power developed, its ability to observe and record the observation, and the last and most important is the mechanical ability should be encouraged. So, according to Halfpenny, the surgeons are made. Then, can surgeons be made? Number one is the competence, because before one becomes an expert, he or he must have developed the competence. Number two, the talent. It can be inherent talent, it can be developed talent, but the talent, some may naturally achieve. This is due to the innate talent, but still they require the adequate practice. And the last most important point is a key challenge for the modern day surgical educators is to devise a training programs that can address three shortfall for every individual regardless of his or her innate ability. So innate ability is there or not there, but it's a key challenge for the surgical educators to develop this. Now, deliberate practice. The concept is based and illustrated by Erickson, who believes that most professionals reach a stable average level of performance and maintain this status quo for the rest of their life. So once you have reached at a certain level for the doing such and such surgery, you will maintain it for the rest of the life. It can be said like that. Deliberate practice per se involves repeated practice along with the coaching and immediate feedback on performance by the trainer. The attained level of expertise has been shown closely related to the time devoted to the deliberate practice in the performance of, like chess players, like musicians, like athletes. They can be talented, but the repeated practice in deliberate practice is the answer for everything. Now, memory in context to the motor skill development, it's also very important. It's linked to the additional managerial process. One should have a perception, one should have a memory, and one should have a communication skill. The other non-technical consideration we should consider about the debriefing, a key educational technique for optimizing learning in surgical setting. A recent study identified as a SHARP study intervention as effective and efficient means of improving performance, feedback in the operating room, performance improvement within surgery are important. Now, these are other non-technical this consideration. These are requisite skill set of a surgical leader. These are the core components, the professionalism. They should have a technical competence. They should have an emotional competence. They should have a motivation, innovation. They should have a communication. Decision making is very, very important. Effective teaching is important. They should have a business acumen nowadays. It's very, very important. And the last and not the least, the teamwork and the resilience. So this is the education which is needed for implication of the delivery of modern day surgical education, an expertise-based approach for the surgical training. However, the great potential for new surgical skills education with an expert performance as a benchmark. Now, these are the hallmark for the current surgical training appears. Number one, sheer volume of the exposure the students need. And the second is a simulation, because has proven to be excellent adjunct surgical education part, offering a safe environment where trainee can repeatedly practice a range of clinical skills without endangering the patient. So this is the hallmark of the current surgical training appears to be. Now the conclusion is very simple. There is a requirement of expert performance in a surgery, identify reliable measures, understanding of the mechanism and acquisition of a surgical competence and expertise, and psychomotor skills which are refined with a sustained deliberate self-practice, memory and deep learning. Other point is non-technical skills which include communication, decision-making skills are the core component development of the surgical expertise, and that is technical dexterity is only one component. It's logical to propose the notion that there are combination of factors that make a surgeon. The most effective method to deliver this training are still in debate. The study of surgical experts have been a focus for the medical education researchers for some decades. The value of such research enterprises appears self-evident. Surgical education training program should be modeled towards developing more effective and efficient experts in shorter space of time. Number two, nurture adaptive experts with the ability to excel the wide range of challenging situations. The benefits derived from targeted training, adequate experience, frequency of performing a surgical procedure. And the last and most important, that it appears that therefore, although innate abilities play an important role in the development of surgical expertise, given the attributes of the modern day surgeon, the literature suggests the surgical experts are in fact made, not born. Thank you so much for patient listening. मैं तो काम तो हो ही गया.